So we welcome the panel. My great pleasure to introduce our second panel. Dr. Connie Price is the Chief Medical Officer of the Denver Health and Hospital. Dr. J. Rappaport, Director of the National Primate Research Center at Tulane University. And Rear Admiral Stephen Redd, Director, CDC Office of Public Health Preparedness and Response. Good to see you again, Director. Doctor, good to see you again. Dr. Price, if you would please commence.
Is it on? Can you hear me? Okay. My name is Connie Price. I'm an infectious diseases physician who for 13 years before becoming Chief Medical Officer served as the Chief of Infectious Diseases and the Healthcare Epidemiologist at Denver Health, our county level 1 trauma public safety net institution in Denver, Colorado, and academic affiliate of the University of Colorado School of Medicine. Denver Health is also one of the nation's 10 designated regional Ebola treatment centers, and I now serve as Chief Medical Officer for the institution. I'm telling you this because it colors a lot of my perspective of what I'm going to say today about preparedness. In addition to my training background, I also have some direct experience not only in thinking and ruling out Ebola and planning for Ebola in the hospital setting, but also as a frontline healthcare worker in 2003 in Toronto during the SARS epidemic. I also investigated transmission of Middle East respiratory syndrome in hospitals in the Kingdom of Saudi Arabia. And have been a doctor through several severe influenza seasons, including H1N1. And as said before, I've had to consider even Ebola recently in my role as an infectious diseases physician at Denver Health. I've had the frustration of trying to create surveillance systems working with the CDC's Biodefense system many years ago to try to help us better detect these incidences. So, as I was saying, these experiences do color my thinking on both our strengths in preparedness as well as many vulnerabilities. And there are some common themes in all of these diseases, including SARS, MERS, Ebola, and influenza. First, in a large-scale event, the capacity of our healthcare system is inadequate. I think we all realize that, and that's why we're here today. Hospitals in most large population centers run at near full capacity on a daily basis. It's part of the economics of how hospitals have to run to meet their margin. In addition to just having the available beds, specific needs such as ventilators, isolation rooms, pharmaceuticals, and access to specialty care physicians also are inadequate to treat a large-scale event. So if hospitals are going to be adequately prepared in a community or region, they're going to have to work together. But how do you get competing entities to do that? These are largely public. My hospital's a public hospital, but many of the larger systems in Colorado are private entity, for-profit entities, and they are not typically interested in working with each other. They're accustomed to competing with each other. And so we have to think about how to break down that barrier and get everybody working off the same script during a disaster. The other issue that's unique to communicable infectious diseases for hospitals is that they're communicable. And there's a lot of resistance to accept a patient into your hospital, especially if they didn't originally present to you. And for good reason, transmission of communicable diseases in healthcare settings is amplified. We saw this from our experience in SARS. Where did the transmission occur in the more developed regions? It really was in healthcare settings. Ebola in the United States, same thing. That's where we saw the transmission. And it's because we do things to patients that artificially aerosolize infectious particles. We have hundreds of contacts a day with healthcare professionals and the patients, and there's many opportunities to transmit that you wouldn't otherwise get in other settings. In addition, the patients in the hospitals are sick. That usually correlates with a degree of infectious viral load or bacterial burden. So all of those things contribute to the amplification in the healthcare setting. And then you put overburdened staff who are taking care of their routine patients on top of a surge of infectious patients. They may then end up breaking protocol in their isolation personal protective equipment, or PPE as I'll call it. So these are challenges, the practical challenges of dealing with these types of events. And preparedness takes time and resource. Without that return on investment, you're not going to have hospitals invest in that capability. You can mandate it, and you may get the typical response to an unfunded mandate, which is, here's our plan. It's 100 pages, and we've done 2 drills. Thank you very much. Now move on. So we need to make this very real. But I think that, even though these barriers sound daunting, and I don't mean to be completely negative, I think we have made progress. We had the opportunity in Denver to test our response recently to a suspected Ebola patient. So on a beautiful Sunday morning, of course it was a Sunday, in July in Denver, all of us were sitting in either our bike gear or climbing gear or whatever, and got a call about a 27-year-old male who presented to our emergency department with fever, nausea, vomiting, and diarrhea. And he had reported recent travel to the Democratic Republic of the Congo. Now, he reported travel in an area that was not at that time, known to have recent Ebola transmission. Still, because of the way he presented, if he were to have Ebola, he would have been at a very highly infectious timing of his illness, and we had no wiggle room to be wrong. So we opted to rule him out, as we call it in medical lingo, and bring him in to have a lab test and a full history and physical done. I can tell you, because of some of the resource we have had since 2014. Remember, I told you we're a regional Ebola treatment center. We've had resource for our nurses to do quarterly drills and our physicians to do quarterly drills on donning and doffing personal protective equipment. We've had resource to build our own biocontainment unit with a lab, with autoclave capabilities, with transport pathways, with dedicated elevators, all of these things to be able to accommodate such a patient. And I was very pleased with the medical response in this event. We feel we have gone a long way, and the structure put in place and the resources of the National Ebola Training and Education Center really served us well. Where we've really had difficulty is what Dr. Fink referenced, is more in the communication and intersecting with our public health colleagues around who's in charge and how to communicate to reassure our public. This got a lot of attention, caused a lot of angst in our community. We were ready to communicate our negative test result by 1 p.m. that day. But because of a desire from 3 different public health agencies wanting to coordinate a response and have a joint press release, we could not get all the approvals we needed to communicate something to our public until about 4 or 5 p.m., at which time then the other entity said, you know what, you guys just do it on your own. So we felt that that could have been much better. We could have been more reassuring and allowed others to go about their Sunday and enjoy that beautiful day and not be afraid of Ebola in their community. Many other lessons learned, and we can get to those in the Q&A session, but I want to give some time also to my other colleagues to give their opening statements. Thank you.
Dr. Rappaport, thank you.
Thank you, Dana. So I'm the director of the Tulane National Primate Research Center. I've only been in this position since June, so I wanted to tell you how I came to have this position and what and I appreciate the opportunity to present my perspectives. The previous director, Dr. Andrew Lackner, had passed away a year ago, April. He was director of the facility during the outbreak of Burkholderia pseudomallii, which I think the panel is interested in. Through that time and through some years surrounding that, I actually had served on the NIH panels that had reviewed all of the National Primate Research Centers with the exception of Tulane. So 6 out of the 7 standing National Primate Research Centers. So that actually I think is why I was one of the candidates or viable candidates. And in accepting this position, I also take responsibility of the Select Agent Program, Biosafety, and and I can give you my perspective on the importance of biosafety, biosecurity, also non-human primate research, and our status of research, I think, with in terms of what's going on in the rest of the world. So the incident that is in question occurred November 2014 to February 2015. We had 3 animals that were 3 rhesus macaques that were inadvertently infected with Burkholderia pseudomallii. These animals were euthanized. The incident was reported. There was an extensive investigation by the USDA, CDC, EPA, and there was a multi-agency investigation and response to the incident, interacting with local officials, together with the leadership and staff that was at the Tulane National Primate Research Center. So we have a fairly secure environment. We are the only National Primate Center that has a regional biosafety laboratory with a select agent program. We have a number of select agents that are in use. This particular incident led to some important lessons. One is that we had to really step up our levels of containment, our standard operating procedures that had to be robust and strict. Dr. Laura Levy, who is the vice president for research, hired Angie Birnbaum, who's here with us today, as director of biosafety for Tulane. She managed the response to the incident, the investigation, and the response, and is now director of biocontainment with the regional biosafety laboratory there. So we had a massive response. We had to examine all of our procedures because it could not be ascertained what the specific step that led to this release of Burkholderia. So everything had to be looked at. So the entire program, the entire biosafety program was revamped, revitalized, and went from something that was questionable based on the release to now that I think is probably the best biosafety program in the nation and has really exemplary status. So we actually have had our, after 16 months, we've had our select agent status reinstated in 2016. In retrospect, we were very fortunate. One, that it only had affected a few animals. It had not spread to any humans. It had not infected the water supply. We had tested the water, the soil. This agent can be found in water and soil, normally in Southeast Asia. It's not found in the United States. It was confirmed that this was a laboratory strain, so we do know where it came from. But we were very fortunate that this incident had not caused more of a problem, within the animal population and also with the human population in the region. So this actually brings us to consequences and our vulnerability for the assessment for future outbreaks. All of the select agents, with the exception of smallpox, come from wildlife, come from animals. We don't really know when the next one is going to be. The H1N1 Zika. These are examples of the unknown unknowns. So it's very difficult to predict when the next outbreak will be, and if it's not really, if it's when. So my perspective, coming as a director of one of the National Primate Research Centers, and I've talked about this with all the other directors, we have weekly calls by telephone. We meet in person twice a year in meetings. We just had one. So we are extremely under-resourced nationally regarding the ability of non-human primates for research, and this includes biodefense studies. Now, I say this is extremely important because the nature of these agents, the nature of select agents is such that the medical countermeasures that are developed cannot be tested in humans. They have to be tested in animals. And the non-human primates are the quintessential, most translatable, most valuable asset in terms of research related to such an outbreak. There was recently a needs assessment performed by the NIH, a survey done by Sherry Hill from ORIP. And the conclusions, which are being written now, are that we are extremely under-resourced with non-human primates. There are certain species that I can tell you about, probably in the next 3 to 5 years, will be 10 to 20% under-resourced in rhesus macaques. And this does not include, this includes just normal research grants, you know, the normal day-to-day. It does not include the surge or an outbreak of consequence, which would divert and necessitate the commandeering at this point of non-human primate research. The biosafety level 4 facilities that we have in this country are few and have very little space. It's been proposed that we should use small monkeys in these facilities, such as marmosets or cynomolgus monkeys. Marmosets right now are extremely rare. There's a demand for them for gene editing studies. A few years ago, nobody knew what to do with them. Now, you can't get them because gene editing studies, the ability to manipulate DNA, to create transgenic animals, to cure mutations or to create mutations, has caused an extreme demand for these. So a lot of these are in matings now to produce more, and you can't really, they're in really short supply for research. The cynomolgus monkeys, or crab-eating macaques, are almost exclusively coming from China. China is selling cynos at lower prices than we can generate them. They're also luring US investigators and some Chinese investigators that came over in the 80s and 90s back to China because they're building enormous non-human primate facilities capable of doing non-human primate research and also with the ability to do gene editing studies. They're charging so small amounts of money. Here it may cost $6,000 for a cyno, over there it's $1,500. So they are luring investigators over there. This is going to be a drain on our intellectual capital, okay? And it's also going to be, some investigators are worried that in the future we will not have the appropriate models here to work with. Now I know tariffs aren't going to do it because that will not prevent investigators from going to China, and I'm not in favor of taxing this supported research. But we have to think about how we subsidize our research enterprise. Right now, studies with rhesus macaques, or with monkeys in general, non-human primate research right now is about 1% of the total NIH budget. If you look at the National Primate Research Centers, who really supply the infrastructure for basic research for non-human primates, we're probably talking about less than 0.25%. So we're talking about fairly small, relatively small amounts of money. But nevertheless, the NIH budget has increased 5% this year to 2019, and probably about 4 to 5% over the past few years. Nevertheless, the non-human primate research centers have not received an increase. Their budget has been basically flat. And in terms of inflation-adjusted dollars, we're actually losing ground. We're supporting more and more research in R01 grants, program projects, contracts that we do for the NIH. We have a vaccine evaluation unit. We do contracts for AIDS vaccines. We do quite a bit of research. That research is increasing, but the infrastructure, the money we have for our infrastructure remains flat or is decreasing. During the sequestration, 2013, the New England Primate Center was closed. That was one of the initial 8. The funds for the New England Primate Center was not distributed to the other 7, despite the fact that many of the resources were distributed. There was some funds that were distributed on a one-time basis, but that sequestration actually, if you look on the graph, I don't have slides to show you, but that actually caused a dip in the funding to the National Primate Centers. So I think that when we think about it, we really need to take action here. The pharmaceutical industry, we've talked about the private sector. Pharmaceutical industry almost exclusively uses cynomolgus macaques. Right now, none of the non-human national primate centers are breeding them. We have an epidemic coming for Alzheimer's disease. It's not another issue, but African green monkeys are probably the best model, and none of the non-human primate centers are breeding them right now. It takes time to establish these colonies, to have the appropriate number of animals in breeding, and to have the animals available to do studies on demand as what happened during an attack. So I think we're quite vulnerable now in terms of our position in the world, given what's going on globally, the fact that our pharmaceutical industry is dependent on China. Studies done in China require specifications of products introduced into these animals to the point that they will be able to acquire the intellectual, or let's say, steal the intellectual property, okay, that would not happen in studies in the United States, where such studies can become, which can be done more confidentially. So I think we're really at a tipping point, and we need to take some actions here. So I have some recommendations, and I know that we were asked to come up with some actionable items, and these require funding. One is the funding for the regional biosafety laboratories. These were put up 10 years ago or so over the concerns over biosafety, thanks to the concerns of this panel and others. There are 13 regional biosafety laboratories. 11 of them use rodents. There are 2 that use non-human primates. We are one. The other one is in Pittsburgh. The regional biosafety laboratories, their construction was supported by federal dollars. There are no dollars available for the maintenance of those facilities. And these facilities are extremely complex and difficult and expensive to maintain. Ours is a single floor, but there's a floor above it we call the penthouse. And if you go in there, all you see is ductwork, okay, and HVAC systems, controls. There's incredible redundancy that's built into these systems. If the airflow were to stop, for example, and we're using an agent, let's say Burkholderia or tuberculosis, which we use, we have a system where we can create aerosols and expose animals to aerosols and infect them in aerosol chambers. If the airflow were to stop, we would have a risk of release infection of the people within the facility. So there are multiple redundancies built in that are tested under conditions of failure. And this is a very expensive to maintain. We are actually in a better position than some of the other regional biosafety laboratories because located at Tulane, we have quite a bit of additional research support. We have access to other funds available that we have been able to do a better job in supporting this, a lot better than the freestanding regional biosafety laboratories. So my recommendations for this is, one, is to provide financial support through the Department of Defense to support strategic reserves. This is actually for the non-human primates, and the actual cost of this would be $40 million to have a non-human primate reserve. And I came up with this figure based on what the cost of the base grant is for what we call the P51s that support the non-human primate centers. And this would be, let's say, a 50% increase on the base grant that would allow an increase in the number of animals should there be an outbreak that such animals would be available.
What was the dollar figure?
It was $40 million. Okay. Additional support for biosafety operations and facilities for select agent laboratories based on size, complexity, and risk. This is $20 million. I think we're probably spending at least $2 million on ours. And ours, I think, is the largest, has the largest capacity, and is the most complex. And then I would ask for an additional funds for select agent research as of $100 million. This is all annual cost. I think without the continued funding for select agent research, there are quite a few organizations, academic institutions that are just dropping their select agent programs because these are also expensive to run. So, we need the intellectual capacity, we need the continuous research, improvement, we need to have scientists engaged in select agent problems, and they and their staff would then be trained to do such research. So without continuous funding, I think a lot of this infrastructure is in jeopardy. So that gives you a cost of $160 million total, annual. And I'd also like to say that we need to engage our biosafety professionals more in terms of the responses that we see, not only in the research setting, but in the hospital setting. As Dr. Price mentioned, a lot of the transmission you see is in the hospitals. Biosafety professionals are a lot more, let's say, have the better training to train others in these practices. I think I'll stop there. Thank you for your attention. Thank you.
Admiral.
Thank you, Governor, and it's a pleasure to be here this afternoon. And I wanted to start by just commending the work of the Blue Ribbon Panel. I think it is very, very important to have voices outside of government continuing to maintain the focus on being ready for health emergencies, whether they are from natural sources, by accident, or by intention. Our work at CDC is intended to prevent these kinds of events when that's possible. When that is not possible, or we don't prevent the event, to make sure that we've got the earliest possible detection and response capability. What I will talk about today is the H1N1 response. I was the incident commander for that response, And I'll reflect a little bit on what we learned through that event, what we have corrected, and then some reflections just kind of from a larger picture of how we need to think about these large-scale responses. First, the events like H1N1, Ebola, and Zika are going to continue to occur and will, over time, occur more frequently because of trends that are evident today. Much more global travel, growth in the world's population, particularly in cities. The number of cities with populations over 10 million was 2 million in 1960. It'll probably be in the range of 40 million in the next decade. Not 40 million, 40 cities. That growth is occurring in urban areas, and much of that growth, virtually all of it in African cities, is among people who are very poor. The likelihood of coming into contact with animals is also increasing, with the number of poultry and swine increasing. There's a chance of contacting domesticated animals, and encroachment on wilderness areas can lead to outbreaks like we're seeing in Democratic Republic of Congo right now. The last trend that I would point out is the availability of communication technology. Overall, that's great that we can communicate around the world quickly and at almost no cost, but it also increases or makes the spread of violent ideologies much easier. We've heard also about the ease of spreading misinformation. So these are things that are making emergencies more likely and more difficult to manage. But let me take us back to 2005. That was when the threat of a global pandemic was really highlighted by the Bush administration, and some very important preparatory measures were undertaken. The H5N1 influenza virus was spreading from East Asia south to Indonesia and west through Asia into Africa. And the U.S. government led a really global effort to be prepared. The UN, the World Health Organization, there was a body called the International Partnership on Avian and Pandemic Influenza. There was also very intensive work with state governments and state health departments to get ready. Secretary Leavitt traveled to every state to meet with governors and encourage preparation. His message was that the federal government will help, but in a severe pandemic, there's not the possibility of focusing human and financial resources, and so states needed to be ready to respond on their own. A national strategy for pandemic influenza was published in November 2005. An implementation plan was published the following May, and there was very detailed follow-up on the 320 deliverables with public reporting periodically. There was substantial funding just for CDC on the range of $1.5 billion for pandemic preparedness, and that was in addition to work after 9/11 and the anthrax attacks to be ready for public health emergencies. We undertook an intensive planning and exercise process. In 2007 and in 2008, we conducted 5 functional exercises. These were 24-hour-a-day exercises where we practiced what we thought a severe influenza pandemic would look like, including mock press interviews, notional conversations with the World Health Organization, with officials high in government, and with state health officers. And in fact, we were planning a 6th functional exercise for the spring of 2009 when the H1N1 virus was identified. We had planned that the pandemic would start outside of the United States, and we would have time to characterize the severity and the transmissibility, but as we know, that's not what happened. We first identified the virus at a weekly pandemic preparedness meeting that took place at CDC. It was on a Wednesday morning, kind of the end of the meeting. someone from the lab on the phone called that a 10-year-old boy in Southern California had been diagnosed with a virus that hadn't been seen before. It was actually part of a clinical study done by the Navy on a prototype diagnostic device. The device would identify flu viruses within 30 minutes, and it gave a positive test for flu, but none of the seasonal viruses. So at CDC, we genotyped that virus and found that it was it was related to swine influenza viruses that had last been seen about 10 years before. And it was really, people didn't know what to make of it. We expected that there'd be an investigation and there would be an exposure to swine at a petting zoo or something. The next day, on Friday, 2 days later, a second case was identified, and this individual did not have any contact with the first individual, and by that time we knew that neither of them up till had any exposure to swine, so we knew something was up. We decided to publish a report on these two cases, and that was done on the following Tuesday, so 6 days later. As we were publishing that, cases were identified in Texas, and on the Thursday, 8 days after the initial detection, we got a report from Canada that severely ill individuals from Mexico had been diagnosed as being infected with that same virus. 6 deaths, 10 people in hospital. And that led to a call with the White House and with people in the Department of Health and Human Services. And there were 2 questions that came up on that call. The first was, how bad is it going to be? And the second is, what are we going to do? I actually think these are probably the same questions that would come up in any event. They weren't things that we had actually practiced answering in our exercises. Rich Besser answered the first question. He said it was an 8 on a scale of 1 to 10. Now, no one knew, really. We had severe cases in Mexico, a handful of very mild cases in the U.S. But later he said he gave that number because he knew it would get people's attention. The second question was, what are we going to do? And I answered that question, and it seems kind of obvious now, but at the moment of getting that question, it wasn't so obvious. My answer was that we would work to understand the severity and transmissibility, kind of how this question of we needed to learn more to be able to really answer the first question. The second thing we would do is we would implement individual control measures. In fact, we'd already done some of that, recommendations for drug treatment, for personal protective equipment, hand washing, covering coughs. And we would begin to implement community measures, begin to develop a vaccine, make decisions about whether schools should be closed or not, and a process of notifying travelers to countries and locations where cases were occurring. There were many, many decisions that were needed in those first couple of weeks of the event. And I think that's also a characteristic of these kinds of events, is that most of the important decisions have to be made before you have all the information. And there's also a lag between making the decision and being able to implement it. In the case of vaccine production, we started production of a vaccine in April and didn't have vaccine to deliver until October 5th. I'm now going to just skip to the end. There were 60 million cases in the U.S., a little bit more than 12,000 deaths, 10% of those in children. We were able to vaccinate 81 million people and probably could have vaccinated more, except the peak of vaccine availability occurred after the peak of disease. Those efforts prevented 10 million cases and 1,500 deaths. So what we learned from H1N1, first thing was that our everyday public health systems provided the foundation for the response. 2 quick examples. The system that we used to track the disease was the same system that we use for seasonal influenza year after year. Our system to distribute vaccine was built on the system that's used to ship vaccines for children. Vastly augmented, but basically using that same system. Second major lesson, it's been talked about a little bit, communication was a major effort. And the aim of that communication was to sustain trust that the government response was effective and that we were being truthful when things didn't go well and when they did go well. Third, medical countermeasures are a key capability. The vaccine, the time to produce vaccine, its effectiveness were not what we would hope for, and antiviral drugs, we had them in abundance, but they're not as effective as we would like them to be. Lastly, preparation paid off. There was some mention about the use of the incident command system, how that wasn't used in the anthrax event. In H1N1, we had a practiced incident command system that we used. It really facilitated internal awareness so that we knew the facts that we knew. In terms of things that have been corrected since the H1N1 epidemic, we have better tools. We have taken weeks off of the time from beginning vaccine production to having it available, and through work primarily through BARDA, we're able to make much larger quantities of vaccine. We still need better influenza vaccines that would be more effective, longer lasting, and would be effective against a broader number of strains where we don't have to make it each time for each strain that emerges. We've developed better means of distributing countermeasures. We have worked closely to increase the throughput of vaccination, primarily by being able to vaccinate at pharmacies. We just don't have enough providers without pharmacies to be able to vaccinate the number of people and the number of doses that we would need to in a severe pandemic. And we have also worked to establish a system of telephone prescribing for antiviral drugs that could be used in a severe pandemic, again, to increase the capacity for drug treatment. We've also worked hard to understand the information that we have so that in those early days when a pandemic is beginning, we can organize the information that we have and compare it to either other pandemics or other seasons of influenza. Just to close now with some overarching lessons, in events like this, it is very important to question implicit assumptions. And the one that I would point out in H1N1 was we were using the same methods to produce influenza vaccine that were used for seasonal influenza vaccine. And so we assumed that there would be a certain rate of production, and that turned out to be a false assumption, that we were looking at it and we were watching it, but this bias that there's going to be about this much vaccine produced per egg was hard to disabuse ourselves of. I'd say also when events like this occur, we need a combination of humility and confidence. And from the standpoint of humility, we need to recognize that initially we're not really going to know what the situation is, and it is possible that a very bad influenza pandemic, it would be catastrophic regardless of how effective our response is. Until we can actually prevent a pandemic from occurring, it could be a really bad thing. I think we have to have confidence to know what we know and take action even when all the information isn't available. Third item here is that overwhelming events will require teamwork across agencies and across sectors. And the best thing that we can do in the short term to improve that is to exercise and make sure that we're making improvements based on those exercises. And lastly, this is the very final thing, we need to be able to measure our capabilities to be able to say with confidence where we're improving and where we're not improving. There have been several efforts in the last 5 years to improve our ability to understand exactly where we are, and I think that those are very important benchmarks to help us really understand how much more we need to do. Thanks very much.
Senator Dash.
Thank you,
Senator
Governor.
Dash.
Dr. Rudd, let me just pick up where you left off with your last comment about measurement. We're talking today about the progress, to the extent we've made progress over the last 17 years since the anthrax experience in 2001. You all come to the table with enormous wealth of experience, with insights and with a judgment that has been based on that experience and your views as you've learned from them. We haven't talked much today yet about the national strategy for biodefense, and I would really love to get, based on your experience and your judgment, what progress you think we've actually made. Frankly, I'm somewhat pessimistic that we haven't come nearly as far as I wish we would have in the last 17 years. On a scale of 1 to 10, I'd give us about a 4. Maybe you can disabuse me of that ranking, but I think it takes 3 things. It takes, first, real leadership. We've had it sporadically. We haven't had it consistently. It takes an enormous amount of coordination, and we've had that occasionally, not consistently. And it takes resources. We don't have the resources applied. And so I think the real question is, as we measure where we are today, realistically, have we adequately prepared? Are we adequately capable of addressing a catastrophic experience way beyond what we did with the anthrax in 2001? To whatever extent you can give us your judgment around those questions as we now apply this new national strategy on biodefense, I'd love to have your insights. Maybe we'll just go down the line, and that'll be my only question.
Yeah, I agree with your assessment. I do think we've made some strides since 2001. And I guess I'm intrigued with each time we deal with these issues, we've learned lessons. How well we've applied them, well, we still have that opportunity. One of the structure that I thought served us well in our Ebola scare was this concept of regional preparedness centers and sort of a tiered system where you have frontline health facilities that really should be able to evaluate or suspect a potential communicable disease coming into the facility and could take care of a high consequence pathogen for 24 hours. Then you have your treatment or assessment hospitals that could take care of a patient for a little bit longer, maybe up to 5 days, resource and capability up to that point. And then your treatment centers and regional treatment centers that could really take care of the patients for the whole duration. For something that is a smaller scale, like an Ebola, maybe even like a SARS, I think that structure would work. When we're dealing with like an H1N1, though, I mean, that would be so widespread that really that structure then becomes more of a resource structure where the treatment centers can maybe inform and provide guidance or, telephonic consultation with specialty support, something like that, to other hospitals, because everybody's going to have to take care of patients. And so, I think we do have to recognize first what kind, are we planning for, what kind of events we're planning for, and really put realistic plans in for the type of event that's most likely and that we're more likely to see. Is it widespread like the H1N1, or are we really worried more about those really high consequence infectious pathogens where we have to detect that first case and, take care of them and prevent transmission.
Yeah, thank you. I agree with what Dr. Price said. I think we have made strides. I think we've come some distance. We have a ways to go. I think Vince Lombardi said, if you strive for perfection, you'll achieve excellence. So I think it's nice to really set the bar high, and hopefully we'll get as high as we can. There are a lot of things we can do. I come at this from from the research area and development of the medical countermeasures. I think we need to do more, as I said, more support for non-human primates. I think we need to do comparisons of various platforms for vaccines. For example, DNA vaccines versus protein vaccines versus viral vectors, killed vaccines, live vaccines. I mean, I think in terms of influenza, it's basically a combinatorial problem. There's only so many hemagglutinins and so many neuraminidase, H's and N's, and whatever the combination is, that's what you have. So to generate the proper combination is, there may be possibilities to do that fairly simply, including multiple hemagglutinins, multiple neuraminases in the same vaccine, or to generate them rather quickly in a platform like DNA vaccine would allow. So I think there could be some research to compare those and try to see which would be the most rapidly deployed in the case of such an event. Thanks.
So in terms of what has been accomplished, a huge amount has been accomplished since 9/11 and the anthrax attacks. Just looking at what state capabilities have been built, every state has an incident command structure, an emergency operations center. They are linked with their emergency management staff so that there's much better coordination within state governments. We've talked about the laboratory response network, so there's that ability to make laboratory diagnoses that didn't exist before the pre-9/11 period. There also are substantial staff in state and local government available to respond that weren't there beforehand. We've made strides in the dispensing mission. When medical countermeasures are delivered to a jurisdiction, there are plans that have been exercised as to how to do that. There's also been important gains in the ability to communicate that are tested regularly. There also are systems to measure those capabilities. I'll point out two. One is the National Health Security Preparedness Index. It's an annual review external to the government that measures each state's capabilities in a number of domains. At CDC, we are working with states to measure their operational readiness. There's a questionnaire and then a site visit to make sure that those plans and exercises are available to demonstrate capability. So I think we've made a lot of progress. I think this is not something that we're ever going to be at a point where we say we are prepared. It's really measuring where we are and building capabilities where we need those and then sustaining them. So I think there is a kind of a capital procurement that's that creating that capability and then making sure it's sustained on an ongoing basis.
Yes, Admiral Red, thank you for your presentation. As you know, I worked on the flu preparation plan with you and the implementation, and I was quite pleased with the success we had in limiting H1N1. But the numbers you talked about in terms of there were between 10 and 15,000 deaths, I believe, and you say that our efforts or the government's efforts prevented another 1,500 deaths. If you look at this year, we had almost 80,000 deaths from flu, and the typical year is about 36,000 deaths. Do you think that H1N1 was an example of a successful response that limited the number of deaths, or do you think it just wasn't really the 8 that Dr. Besser had feared it would be?
I think it turned out not to be an 8. That would be one thing. I think that the measure of success was largely that we were able to maintain the trust of the public And that was not by saying it was going to be worse than it turned out to be, but by ongoing communication about what we knew about the severity, what we were doing, what members of the public should do. We actually had, in the summer of 2009, we invited media to CDC for a week-long media boot camp to teach them about influenza. And I think there's not many events that have a beginning and then a lull and then an increase, but I think that was a great opportunity to really tell people what we thought was going to happen and what we as the government would do.
Yeah, that's a really excellent point. And I just want to make one quick follow-up, which is if you all remember that this took place in March of 2009 when we just had a new government, and at that point, for a variety of reasons, there was not a single confirmed political official at HHS at that point. And so the career staff really did a tremendous job in that communication, in showing a kind of a government spirit and showing that they were in charge and they had the expertise, and it really was an example of the system working well, even in a period of transition and flux.
Colleagues, anything else? Dr. Rappaport, first of all, on a personal note, I noticed you work at the Lewis Katz School of Medicine at Temple. Lou was a great personal friend of mine, an extraordinary philanthropist, and I suspect your association was even in a personal and professional way deeper than mine. He was quite a remarkable man, wasn't he?
He sure was, and we're very grateful that, he endowed the School of Medicine, and he really changed things there so much for the better.
Yeah, no question about it.
Yes.
Given your work with HIV and with primates, you're just the person to ask this question. I read articles from time to time that tell me that computers and artificial intelligence can ultimately substitute for the kind of work you do on primates and other animals. And I'd like you to address that from your experience.
Okay, from my
Pretty open-ended question, so
okay,
take it wherever you want to go.
Okay, I just give you an interesting story. 1995, when the first protease inhibitor was discovered, David Ho was on the cover of Time, Man of the Year. HIV was cured, okay, because their mathematical models predicted that if a patient was on antiretroviral therapy long enough, the virus would be extinguished. This was all based on calculations, mathematical models. So I think what you put into the computer and what is really determines what you get out. And a lot of it is based on your assumptions. If your assumptions aren't correct, then you're not going to get the right information. Right now, even with HIV, I think we're lacking the full information, and more information is coming every day in terms of what the best methods are for cure, vaccines. And so right now I don't see that the computer's taking over, because we would have to input to them all of the correct assumptions and all the information the computer needs to know, and still we're trying to figure it out. When the computers can start doing experiments and start coming up with hypotheses and testing them, and I know there's something called machine learning, but there's still programming involved there, and we're still driving the ship with that. So right now I think it's dependent on us to do the research and use the computers as we can to test hypotheses.
Yeah, I appreciate the candor. I thought about that in terms of everybody thinks they can run. I mean, it's an exciting world for science and technology and the collaboration, but I guess I personally wouldn't want to rely on it exclusively for any medical countermeasure. I'd rather, the combination of both will serve the country well, I would presume.
Absolutely.
I appreciate that.
Absolutely.
Dr. Price, you said something very interesting, and I made note of it. You were out, the team was out in a nice July day. You got a bunch of calls, but there was no wiggle room. I like that, no wiggle room to get the diagnosis wrong. Now, you were at a regional Ebola treatment center at the time, so that center and you, because of your experience and apparently several other people there, everybody pretty confident you weren't going to get it wrong, and you didn't. So the question becomes, one, do all the regional centers, be it for Ebola, and I'd like to know if there are other pathogens, have people such as yourself and people with the experience in these particular specialties, and is that how either regional treatment center is created, or do they place the specialists such as yourself to create a center of excellence?
Yeah, so we had to apply to be a regional treatment center, and as part of that, we had to have the capability so that the specialists, the ability to diagnose, and those resources. And part of what we need to do, I think, better going forward, should this structure continue, is the outreach to our rural hospitals to provide, to teach them how to identify, some methods they can use, and even just everyday infection prevention as sort of their backup. So, for instance, you don't have to be an ID specialist to know that if a patient comes in with a cough and fever, you don't want it, whether it's SARS or whether it's just the common cold. And can we start moving all of us as healthcare providers on the front lines to a paradigm where this is just our routine, that we have this approach to evaluating patients as sort of that backup measure? I think that's what we need to start working with all of our community counterparts on. I mean, the analogy would be pre-HIV days. Remember, we used to draw blood without gloves. You can't even, it would feel funny to do that now. And I think we should start thinking about it for other just high consequence infectious diseases, and just the regular everyday infectious diseases we don't want.
I appreciate that. Unfortunately, we've got such a time crunch, but we appreciate this panel's your contribution to our discussion, and thank you again for your broader service to the broader community, not just in your individual communities, but to the country. Thank you very, very much, Admiral. Thank you.